Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Micheal Darson, and in today's episode, we will discuss sustainability in urology. We will view this through the lens of a unit in New Zealand and its transition from the OR to the office of its transperineal prostate biopsies. This single procedural change offers a unique opportunity to explore sustainability across its three interconnected dimensions. Joining me today for this discussion is Dr. Wikus Vermeulen, a consultant urologist in Tauranga Hospital in New Zealand, and the senior author of a recent case study examining the transition of transperineal prostate biopsies from the operating room to the office, a model that has become a reference point for other sustainable urologic practice changes. Dr. Vermeulen, his clinical focus is on prostate and bladder cancer, and he has spent part of his career working in Africa and other resource-limited settings, experiences that shaped his pragmatic, systems-level approach to healthcare. Beyond clinical medicine, he has a strong interest in healthcare economics and value-based care, completing an MBA in international healthcare with a thesis on sustainability within the operating room environment. He now combines those strands, clinical excellence, operational innovation, and economic insight to advocate for more sustainable, data-driven, and equitable urology across health systems. Dr. Vermeulen, welcome to the podcast.
Thank you, Dr. Dawson. Happy to be here.
So let's talk about sustainability in healthcare. Kind of give us some background.
Yeah, I think sustainability is a well-known concept in the business world. It really gained traction in the 90s, and healthcare in many ways has been late to the party. And I would say the last 10 years, healthcare joined the fray. And we can maybe talk a little bit later why that is, why healthcare is so resistant to change. But in essence, sustainability has three domains. It has your economic viability, which is also a cornerstone. It is environmental responsibility and social impact. And in essence, you've got an organization or a business who should commit, when looking at its monetary or financial goals, not to negatively affect any of these domains. Now, they always talk about the triple bottom line, or people, planet, profit. And just to make it easier and to make it more understandable. And in essence, the thing is, the word sustainability means a lot of different things to people. Right. And there's a lot of emotion attached to it. And when you use this word, you often find people, it will range from enthusiasm to rolling of eyes to boredom. And I think it's because there's so much social media and different narratives. And you basically, because it's a complex problem, you kind of choose whatever fits your core values and beliefs. But I think it's important that us as healthcare professionals need to move away from this, because it's not about being fashionable or being green or being politically correct. It is about ensuring that we have a healthcare system and model that will be stable and would provide quality healthcare for future generations, because future generations are also the stakeholders in this. It is people, planet, and profit, but people very much includes our kids and their kids and so on. And I think that's why it's important that the current models out there, most of them, there is no perfect one, and almost all of them will not be sustainable into the future. So yeah, one can dive a little bit deeper into the different aspects of that, I guess. And something that I think is also quite important is that if you look at, for example, the planet portion of it, that if healthcare was a country, it would be the fifth largest contributor to greenhouse gases, just placing it in between Russia and Germany. So that's about Russia and Japan, and that's about 4.4 to 5% of global greenhouse gas emissions. And there's many stats like that that kind of drive this, both in the people as well as the profit domains. And I think we can delve into these ones separately.
Well, that's actually a fascinating way to think. I mean, you're right. Sustainability has a lot of different meanings to different people, and it does. It can evoke emotional reactions and, like you said, rolling eyes or enthusiasm all across that spectrum. And to think of healthcare as, economic viability, environmental impact, and social impact, it's kind of a new way to think, I think, about healthcare. How widespread is this way of thinking?
Again, I think if you look at the business world, it is very much actual in all fields. And I think in a developed capitalistic system, which is the economic models that work the best currently, everyone is embracing that, because chasing short-term profits and not being far-sighted will, in the long run, affect the other domains negatively and then make the whole system collapse. But make no mistake that the thing that speaks loudest to executives and managers is the money. And I think that the moment you hear the word sustainability, you're thinking, oh, here we go, it's going to be about greenhouse gas emissions and this and that and equity and diversity and inclusion. But it's not one of them. It's all of it. When we talk about people, we talk about, yes, workforce diversity, equity, inclusion. We talk about the doctors not having burnout. We talk about working condition. We talk about equal opportunity to healthcare, to distance travel to a clinic, for example. Environment, of course, we want to reduce and recycle and reuse. I mean, we want to limit the ecological footprint of healthcare. And when we talk about economic stuff, healthcare is exceptionally wasteful. I mean, in the US, the estimate waste of money wasting is around $750 to $900 billion a year. If you look at hospital-acquired infections, they conservatively estimate this to be $45 billion a year in cost. So there's loads of room for improving efficacy using a sustainability model.
Those are some staggering numbers. So, well, let's get into the process of transitioning transperineal prostate biopsies from the OR to the office. It sounds like a fascinating project.
Yeah, and I think it's got a bit of a backstory to it. I think you would know, Mike, that there is probably no other environment as resistant to change than healthcare, or specifically a hospital. It is a very difficult environment to instigate change. It's absolutely built on routine and hierarchy, and it is completely embedded into its workflows and its mindset. And business people who study change in business, like Kotter and these guys, find that understandable, and they attribute it to safety, patient safety, protocols, accreditation, medical legal risks. So it's completely understandable that healthcare is very difficult to change things. And we were very aware of this back in 2021 when we started transitioning. Maybe just for the audience who doesn't understand that the two ways of biopsy, if you look at the history of prostate biopsy, it started out in the early 20th century as an open transperineal procedure, just before you completed the radical prostatectomy through the perineum. And then it kind of changed into a transperineal blind biopsy here in the 1950s. But all that changed in the 1980s when transrectal ultrasound was developed. And now suddenly you could visualize the prostate, and transrectal biopsies became the norm. And that really stayed like that for 25, 30 years. But because of fluorokin resistance, sepsis after trus biopsies, the transperineal route became popular again. And but the issue with that is it couldn't be done in the office because you use what we call a grit stepper, which is a 8 by 8 centimeter, almost like I like to explain to the patients, almost like a game of battleships, So you have multiple holes where you stick your needles, and that area is too big to locally anesthetize. So that's why it's done in GA, almost like the doctors doing, the urologists doing brachytherapy will know this grit stepper very well. And but yeah, then what happened is that there was first a freehand technique and then numerous devices to tether the needle to the ultrasound probe. And that made it possible to anesthetize only two small entry points, one left and one right. And suddenly it was an option to move out of the theater into the office. And more and more people, urologists started doing that. So that's kind of the background that we were working on. But now, knowing this resistance to change, we had to do a lot of canvassing to do this, and we planned it in a staged fashion where we first acquired the precision point device, which is locally produced in the US. Dr. Alloway from Baltimore area, and we explained the plan to the executives and the quality assurance people in the hospital, and then first did 20 cases under GA, doing all the steps, but familiarizing the staff and everyone with the procedure and ourselves. And then we did another 20 cases in theater, but with the anesthetist there if we needed conscious sedation. And then the anesthetist left the room and went to the tea room, and we did 40 cases with them not in the theater. And then we moved to the office and started doing all of it in an office setting. And I think that helped because all the way while we were collecting data that we used to constantly reinforce the quality assurance and the safety personnel that we are doing the right thing. We're not negatively influencing patients. We're not compromising outcome or accuracy, and we are experiencing no complications, And I think that was crucial to not have our efforts being stopped by the numerous management and safety departments that will get very scared if they don't know what's going on.
Can you give me and the listeners an idea of a couple of things? Obviously, when we're talking about sustainability, the economic viability is one of the three domains. Can you give me an idea of how long it took you to do the first 20 patients per case, and then the second step, and then the third step? And obviously, time is a huge metric in the operating room. And can you give the listeners an idea of what that kind of cost savings was as a way?
Yeah. I mean, we weren't actually modeling costs in the transition zone, but when we talk about profit, which is actually where you've got to start, because that speaks the loudest to executives. That's the one they want to hear first. But if you compare the costs, a cost for a transperineal prostate biopsy in theater is around $4,200. The cost of the same procedure in the office is 3 times less, $1,400. And that is simply because you've taken it out of the theater and you don't need the anesthetist and anesthetic tech. Of course, it's much quicker, because you don't have the surgical admission units, all the paperwork that comes with the theater, all the nurses involved in clocking the patient and going through the normal theater protocol. And so local anesthetic will always beat a GI procedure in terms of cost and also in terms of speed, because the patient doesn't need to be recovered. He doesn't need to wake up. He doesn't need to have X amount of time before he goes home. But I think the most important thing to know with money is indirect costs. And if you look, example, at the US, you guys do around 2 million prostate biopsies a year. Europe does around 1.8 million a year. If you look at conservative urosepsis figures for transrectal biopsies, is around 1 to 3%. So you're talking about 20,000 to 60,000 patients developing urosepsis and then getting admitted. Now, there's numerous studies on this, and the average cost of such an admission would be between 9,000 to 20,000 US dollars for admission like that. Now, you do the math from there. We looked at it in our own unit, and since we've got rid of TRUS biopsies, we haven't had one episode of urosepsis. And the average cost of urosepsis in a New Zealand hospital is $7,500. So just getting rid of those patients already has indirect cost savings. Now, the most important thing is antibiotic resistance. So in the 19s, there was an incidence of about 1% fluoroquinolone resistance. This is now currently sitting at about 30% in a place like the US. Some countries as high as 50%, where ciprofloxacin is unusable. Now, that indirect cost you can't even calculate, because that spills over to other fields. I mean, if you look at the AUA guideline, for example, one of the options is extended antibiotic prophylaxis before a transrectal biopsy. So meaning you've got to add something like ertapenem or other drugs, which, you know, now it becomes a very difficult, complicated sum to see how much money you're wasting. And that's why I come back to that $750 to $900 billion that is wasted every year, you know.
These are just staggering numbers when you display them like this. So you kind of went over some of the steps, you know, the obstacles you had to overcome, the administration, all that kind of stuff. How did you use the data to ultimately drive the change?
Yeah, and I think that there's different components. So you need to convince the executives, and I think the financials is what they want, right? They don't, they're not much interested in anything else. The second group of people is you've got to make sure that socially this is the correct thing to do. And there we had several good carrots and sticks, you know, to drive it. So first of all, you want to know whether this is going to be a negative experience for the patient. I mean, we had visual analog scores looking at everything, every single patient. We still do them because we keep on collecting, is anxiety, pain, were we looking after your needs? And a very important question in all of these scoring systems is, if you were to have the procedure again tomorrow, would you have it again? You know, so we were very sure all along the way, and we got better with time. Learning curve, looking at around 50, that started dropping off most of the scores, 2 out of 10, 1.5 out of 10, which is really what you want to be aiming for any local procedure, you know. And most people will have it again. So we need to appease our quality assurance and our safety managers also, that we're not doing something that is traumatizing patients. So I think that's the second obstacle, well, not obstacle, but the second group of people we need to. And if there was something, you know, we found that our anxiety levels was initially high, and we spent extra times creating an intervention, extra time beforehand, talking again about the procedure, putting some music on, having a support person at the top talking nonsense to the patient.
Right.
I've developed a whole repertoire of jokes, for different personalities, just to kind of distract them, because it's never a painful thing. But I mean, it's bloody embarrassing, right? So you're awake while your legs in the air, people are sitting in between your legs, there's a nurse there. So we found all these literature on other local procedures. What do they do? Everything ranging from having a VR set on to music to this or that. And we took what we learned from this research and we developed our own protocol, and we found that dramatically brought down our anxiety levels in patients. And so much, like, we have no need for any sedatives. That would defeat the point, right? We also don't use any anxiolyticants. On occasion, we would find a really anxious patient, and you might use some nitrous on them, but that would be the vast exception to the rule.
And how did you, in the US, most places are still doing transrectal biopsies, right? How did you approach the staff and get the buy-in from all the other folks involved in this that were so used to doing it, the old way?
I think it, they always, just to fall back on the social point, of diversity, you find in a unit like New Zealand or Australia that we have all diverse backgrounds. We're all coming from somewhere else. And I think lots of us has done this in different parts of the world already. And that helps a lot if you've got a diverse, open-minded team. Secondly, trust biopsy is an easy sell, because you just need, which we had in 2021, one patient dying of urosepsis after the trust biopsy, which led to a MNM in the whole rigmarole. So it's a very easy sell to get rid of trust. I don't think that is the problem. But yeah, you need to drive this, you need data. And for that, you need buy-in from the residents, because you as a consultant cannot collect data solely on every single patient. And I found that this is an impossible thing to do without the team of residents and nurses and consultants. And that data was crucial in driving further chance. Why would the residents buy in? It's the right thing to do. It provides them, I'm sure it's like this in the US as well. It is extremely competitive and difficult to get into urological training. Mm-hmm. And one of the things they need to do is publish and have multiple articles and experience. So they have enough reason to buy in and contribute, because they will get lots of these type of things out of it. So and the workflow is easier. The buy-in from the nurses is simply that, it's much easier to run a couple of biopsies through a clinic than it is through the theater. So they'll always be on board with it. Again, if our urological service is kind of outsourced to a private company for which I work in this hospital, and how to get their buy-in was easy. That we improved capacity for theater, because by moving this out, we opened 12 whole-day theaters a year, which shortened the waiting list on our cancers, because it's a public system. We've got long waiting lists for operations. So that's how we convince them that it's the right thing to do. So I think each of these, and that would differ depending on what healthcare sector you are, but each of these people that you need to buy in will have either a stick or a carrot, and you got to identify that. And that makes it very similar to any business, really. It's not different to any other organization.
So what is your best estimate at how many, so we'll start with New Zealand. How many prostate biopsies are done transperineal versus transrectal right now? And then what's your best guesstimate for what that is in, say, the United States and Europe?
Well, I think that it's difficult to put a a figure on it. The last figures I saw in the US, around 50% of biopsies are still being done in the trust way, but it is difficult because you guys have duplicated systems, right? So you've got a public and you've got a private, and it's always difficult to get that data from from the private sectors. You can kind of reverse engineer it by using the incidence of urosepsis after a biopsy, because that needs to be reported. And that's, I think, how they came to the value of around 50%. In New Zealand, I think most would be transperineal. I think there's one or two big units still using transrectal. So I'm not sure in New Zealand, but my guesstimate would be that 75% of it is being done transperineally.
Yeah.
How many is done transperineally in office? That would probably be also around 50%. But definitely the march away from transrectal is very strong, and probably would be completed within the next 5 years or so, I would say.
Yeah, it's interesting. I kind of retired from private practice in 2022, and 100% of our groups were transrectal. We weren't even doing transperineal at that point. But I know the transition has started, and certainly in the higher powered academic places, they're doing transperineal. So it's like you said, it's ultimately, it backdrops to it's the right thing to do. And fortunately, I've never had a patient die from urosepsis, but I've had a couple people get pretty close, and it's just an awful feeling. So it's super interesting. So, you talked about the 3 Ps, people, planet, profit. We've kind of parsed out some of the profit. We talked about indirect savings, somewhat about direct savings. How about capacity increases?
Yeah, our unit had a 10% increase in capacity. Obviously opening up a theater will do that. We are very tight, from a public perspective, and very tight key point indicators where we have to, depending on what type of cancer, we've got a limited, you're on the clock, right? You gotta do bladder cancers within this time limit, prostate cancers within this time limit. So that helped tremendously. But it's almost a double-edged sword, because your efficacy in the biopsy now, the rate limiting factor is no more the theater. So now our biopsies went from around 110 a year to 300 a year. And that means no one's really waiting long for the biopsies anymore. Mm-hmm. So now you increase the load of your cancer detection, and
right.
that spills over to your theater. The new capacity you created are quickly filled up.
Right.
So, but all the while we're providing better care, right? I mean, that's the bottom line.
So so there's obviously increases in capacity in the operating theater. How does it bog down the clinic then? How long does this take you, and how do you efficiently incorporate that into your clinic days?
Yeah, so we have special clinics for biopsies, and I think a biopsy would, as a whole, from entering to leaving, about a half an hour. The biopsy itself is really quick. That's 15 minutes max. Taking calls, even less. Most of that goes in talking and prepping, and it really goes quick. And it's evolving ever. When most of the guidelines would say you do targeted, we have MRIs on all the patients prior to biopsy. So you would do targeted plus template. I think most of us, although it's not in the guidelines yet, are moving towards only doing targeted biopsies, because on data we have, it makes very little difference. So that means you're going to do 4 calls instead of 4 plus 12, and that, or maybe just one side, right? So it makes it really quick. And it's ever evolving, right? I think unless your unit is offering focal therapy for prostate cancer, this is definitely the way things are moving. We've already looked at it specifically on active surveillance patients, our active surveillance cohort, and whether we did target plus template, made no difference. It would have made no difference. We obviously did target and template and then analyzed it and showed that if we stuck to just the target, it would have had the same outcome. So I think that makes it even quicker, right? So you could definitely be in and out there under 10 minutes, which there's just no way how a theater case can ever compete with that. But plus the patient will drive in and drive home. He
Right.
doesn't need somebody coming with him, and that makes it much better for them.
Well, let's switch to another P. Let's talk about planet. And I was very interested in your comments about the carbon footprint and healthcare being the fourth largest contributor to greenhouse emissions. And so, yeah, just kind of expand on that.
Yeah, and again, very emotionally charged topic, depending on what your views is about it. And we, I don't think us in medicine needs to politicize this, right? So we just need to measure it, and we need to do better, and that's what we did. So we're very proud because we're the first unit that actually quantified a transperineal biopsy in the office setting, and that came down to around 70 CO2 equivalents, kilogram CO2 equivalents, which in if you have to put it into perspective is around driving a medium-sized sedan around 280 kilometers. So it's not nothing, but it's also not, that high.
Yeah.
Yeah. But and interesting from our data, because you've got to measure it, you got to change things and remeasure, but you also have to have usable data. So the real interesting thing, and I think obviously we in New Zealand, we're in the corner. No, most people don't know where New Zealand is. It's kind of close to nothing, right? And except Australia. So our procurement was 3/4 of the greenhouse gases was coming from procuring the gun and the precision point and the drapes and all these things. Obviously, in an industrialized country like the US, procurement will be much lower because you don't have freight that needs to come from somewhere, right? Well, maybe from China, but the second most one and was very interesting as well. It was travel. It was 24%, if I remember correctly, both the doctors and the patients. And that's when we realized, wait, what's going on here? We need to look deeper in how far are our patients traveling. And we noticed that it's quite a bit. And they're not just traveling for biopsy. Remember, I've already seen this patient in consultation. Then they would travel again to have the MRI. Then they would travel again to have their biopsy. And then they would travel again to come and chat and possibly get treatment. If they get radiation, they're going to travel a whole hell of a lot, right? Yeah. So now we started seeing this and we started thinking, well, okay, let's pull this over into people and let's look at equity in healthcare and who has access, but also what can we do to change it? Should we be going to these pockets where people have to travel from far? Are there enough to make a biopsy bus a option? Should we take our circus to them? And now we've got data to see whether it will work. We also have data to approach NGOs to ask for funding, like Prostate Cancer Foundation and these type of NGOs. But also, shouldn't we rethink it like units in the UK where we have a one-stop shop? So shouldn't you come in, have the chat, have the MRI, if needed, have your biopsy, and then we'll give you the results over the phone, and we'll have a second visit to iron out the fine detail, So it opens a whole way of thinking and problem solving, which you wouldn't have arrived at if you didn't have data. Mm-hmm. And I mean, we didn't anticipate this traveling being such an impact on the environment. And that's what I mean. It's not the environment anymore. It's now it brings in people. It brings in social impact. It brings in questions like, oh, is it the staff traveling? Should there be collective buses bringing the staff in? Should a new hospital that's being planned be built closer to where start? There's so many things that that if you start scratching, you if you have a problem solving type of attitude, you will build the hospital for the future. There's certainly a case like this in Australia where they try to from scratch build a hospital with all these things in mind, specifically something like travel. So yes, I do think it's that was a big thing. And also if you look at Planet, also if you stick with that, should we biopsy everyone? And I think that's where we developed a online risk calculator, where we could actually avoid some biopsies safely, because we utilize machine learning to build this and validated this in other countries as well. Currently, we're actually being validated at Cleveland Clinic to see whether it works in a US environment. And right, that's the best for everything, right? You don't need to biopsy. You can safely have a number for a patient, and it will predict whether you're at high risk of cancer. And I mean, then all 3 Ps win, obviously. You avoid a biopsy altogether.
Right. Very interesting. Yeah, I'll tell you, the travel aspect of it really came to light for me during COVID when we started doing telehealth, because I spent most of my career in the Phoenix area, Arizona, and we would have patients come, 2-3 hours one way, to get their PSA results and their rectal exams, and being able to save all that made a huge difference to the patients. I mean, it was pretty dramatic. So definitely, I see your point there. Well, let's talk about the people, the final P.
Yeah, and I think again, depending on the environment you are in, that's all over the world I've ever worked in areas where there is inequality in access to health. When we started scratching about distance traveled, we started, well, let's see if our indigenous Maori population travel further than our non-Maori population. Now, the Maori in New Zealand, just to give some background, has always been having poorer health outcomes than the Pākehā, which would be the New Zealanders of European descent. Now, there's obviously multiple factors in there, ranging from genetics to access to healthcare to attitudes towards screening, and you can go on forever. But obviously, if you have hard data on traveling, for sure that would be one. And we noticed from our database that our Maori patients traveled 58 kilometers further than our non-Maori population. So that's a hard piece of data, right? And that's very useful to use to advocate for things like outreach projects or biopsy buses or one-stop shops. When you look at people in the sense of the healthcare workers, has it made our life better? For sure. I mean, who's not going to do a half-day clinic biopsies compared with a full day in theater? You're more efficient. The nurses would agree on that as well. What about waiting times? I mean, we talked about that. That would fall under the social impact of it, for sure. I mean, we've dramatically increased capacity and brought down waiting, not only for the biopsy, but also for other cases, which has now access to theater earlier. So I think all around, the people component was also easy sell to, and it always is, because I think our healthcare systems here are set up very much to have social responsibility and to try and promote marginalized communities and try and establish equality of care. Again, the machine learning model helped a lot there, because I mean, what patient is not going to be over the moon if you have a Pirate 3 kind of wishy-washy parameters, and a model could more accurately predict than any of the individual parameters whether a biopsy is needed. Of course, I mean, you're going to be over the moon if you don't need a biopsy. So I think that reduced our biopsies by around 30%. Which is considerable amount of people with negative biopsies. I mean, to be fair, what will happen in the future? I mean, I guess like most things, there would probably come along a very accurate imaging one day, which would make biopsies obsolete. I don't think PSMA PET is there yet, but it might be something like that, or maybe combined with genetics. And maybe we don't need to biopsy anyone in the future. But at the moment, I think the machine learning models or the predictors are pretty much the best thing we have to try and avoid unnecessary biopsies.
Yeah, I tell you, this has been a really fascinating talk. I mean, I think one of the things that I've learned from this discussion is, listen, we have a great new tool, artificial intelligence, all that. If you see something in medicine that doesn't make sense, try to make it better. And that's what this project has done.
Yeah, and I think I might add that this is just biopsies. I mean, you can apply this principle to anything you want to do. We certainly have applied it to numerous changes, and it doesn't need to be always an in theater, out of theater situation. If you want to transition, for example, HOLIPs from to day cases, for example, you instead of multiple day admissions, just change your technique or do this or that to make it a day case. The same principles will apply, exactly the same process, and you use the same data. You use data to convince, just like so, or something small like you want to change a administrative workflow, or you want to get rid of unnecessary urine MCNSs, or you want to see should we be doing flexible scopes on everyone with microscopic hematuria. Lots of countries, I mean, that's a large burden on the system. Lots of countries in Scandinavia has done away with this, feeding their data into models saying, well, listen, your pickup rate is almost zero. So why are we doing this? Why are we wasting money at this? So I think it's not just about the biopsy. I think it's whatever you think you want to change and make it more efficient. Just be sure to collect data and see if you're doing the right thing, but also using this to try and get rid of all the obstacles that will be inertia to your change.
Yes. Well, listen, thank you very much, Dr. Vermeulen, for sharing your time and expertise with us today. And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel. Again, thank you.
Thank you, Mike. Pleasure.
Make AUA Leadership and Business your go-to podcast. Subscribe today by searching Leadership and Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.